I will discuss under following points what is wearable cardioverter defibrillator, how does it function, what are the studies supporting WCD and indication and recommendation, and what are the limitations, and what are the take-home messages. So as you all know, ICD improves sudden cardiac arrest, survival from, and it also improves the overall survival in patient at the high risk of sudden cardiac death. But there are certain situations where you need to put an ICD, but you can't put due to certain reasons. Like patient is having some infection, or in immediate post-MI situation when the benefit is not proven, may not be covered by third-party players in a new onset heart failure, or when an ICD must be removed for a short period. So what is a wearable cardioverter defibrillator? It is an external device and it is capable of automatic detection and defibrillation of ventricular tachycardia and ventricular fibrillation. It consists of mainly two things, a garment and a monitor cum defibrillator unit. So this is how it looks when it is on. There are different components. There are ECG electrodes. There are 4 ECG electrodes, 2 in the posterior side and 2 on the anterior side, these blue dots. Which monitors the rhythm, and there are a vibration box, and it gives alert to the patient when the arrhythmia is detected. And there are 3 self-gelling defibrillation electrodes, 2 on the posterior in the back on the right and left interscapular space, and 1 at the apex in the anterior side. And there is a monitor cum defibrillation in it. It weighs around 0.8 kg and generally worn on the belt. Can be worn on the soldier strap also. And there is a response button on this monitor cum defibrillator. There are 2 response buttons, one anterior, one posterior, which the patient press when he is conscious, and there is an alarm from the device that arrhythmia is occurring. And if patient is conscious, they press this button and the shock is aborted. And this button should be held and pressed only by the patients. This is how it looks when it is on. It gives 3 types of alerts: vibration alerts, gong alert, siren alert. First it starts vibrating, then it starts giving siren with increasing loudness, and then very loud alert whenever the arrhythmia occurs. So what are the general guidelines for the use of WCD? Before wearing WCD, one should remove all clothing from upper body. It should be worn beneath the cloth, not above the cloth, even in the undergarments. The garment must press against the bare skin. This should be firmly pressed so that all the frequency can be detected, ECG abnormality. Batteries should be changed every 24 hours. There are 2 batteries given with the device, and battery is inserted in the monitor cum defibrillation unit. And one should wash the garment every 1 to 2 days. No one except the patient should press and hold response button. And one should contact treating physician immediately if the shock is delivered. The only time one should remove WCD is when taking short shower or bath. So how it detect and deliver shocks? So arrhythmia detection is programmed using ECG rate and morphology, as it is the general trend. It uses the 2-channel proprietary vectorocardiogram morphology. And if that algorithm, when the arrhythmia occurs and the QRS doesn't change, then it presumes it is SVT and the shock is aborted. Typical rate is VT from 150 to 199, more than 200 VF. And this device can give from 75 to 150 joule biphasic joule shock for up to 5 shocks. So these are the alarm sequence. The patient is normal syndrome, and when the arrhythmia occurs, it is detected by this device, and vibration alert starts, and it continues. Then the siren alert starts, and it continues throughout the sequence. Then third step, siren alerts get louder. Then patient hear the audible prompt that electrical shock is possible. Then in the 5th, the defibrillation gel or the auto release gel, the blue gel is released automatically whenever the device decides to shock. So the gel get released, and then bystander audible prompt. One should not touch the patient. Any bystander should not. If the patient is unconscious, the machine will give prompt that don't touch the patient because it is going to give the shock. Then the last stage is the shock. After the shock, the normal sinus rhythm is restored in most of the cases, and the whole procedure takes around 25 to 60 seconds. So what is its effectiveness? The detection algorithm has sensitivity of 90 to 100% and specificity of 98 to 99%. SOP efficacy rate is 69 to 99. In most of the studies showing around 95 to 99%. Inappropriate shock rates are 1 to 2%, and the response time is 25 to 60 seconds. This wearable cardioverter defibrillator stores data regarding arrhythmias, patient compliance with the device, noise or interference with its proper functioning. It stores ECG from both tachyarrhythmia and asystole. It captures 30 seconds of ECG signal prior to the determination of VT and VF and continuously records until 15 seconds after the alarm stop. It also records asystole when the records asystole when the ventricular heart rate drops below 10 beats per minute or become asystole remains for 60 seconds, and it records the 120 seconds of event preceding the asystole event. Patient can also perform manual recording if he presses the response button for 3 seconds continuously, then it stores data 30 seconds prior and 50 seconds after that activation. So there are many studies done, and in all of the studies, the first was Wear It and Broad study, and then there are many registry and observational studies. There are no randomized controlled trial till date, and the survival was around 93 to 85 to 90% and 99%, and inappropriate shock rate from 1 to 2%. This is the recently concluded registry, Wear 2 registry, in which there are 2,000 patients, and the median of days 3 months, the patient who or the WCD. 120 episodes of VT-VF was seen in 41 patients, and patient pressed the response button to avoid shock delivery in 90 episodes. The majority of sustained VT episode terminates spontaneously. Remaining 30 VT-VF episodes in 22 different patients were successfully treated with a single shock. So what are the indication recommendations? The AHA Science Advisory in 2016, based on all of the studies, has proposed the indications of this WCD. The first and foremost is when there is an indication for an implanted or permanent device accompanied by transient contraindication or intrusion in ICD care, such as infection. Class 2A C indication is there. Then as a bridge to more definitive treatment such as heart transplantation. Patient is in need of heart transplantation due to heart failure or any other cause. And when there is a concern about heightened risk of sudden cardiac death that may resolve over time or with treatment of left ventricular dysfunction, like in a case of ischemic heart disease with revascularization, newly diagnosed non-ischemic dilated cardiomyopathy, when patients start guideline-directed therapy and they have to wait for 3 months, and secondary cardiomyopathy, tachycardia-induced or thyroid-induced, that are potentially reversible, will have to wait for some time. And as a bridging therapy in situation associated with increased risk of death in ICD have been shown to reduce sudden cardiac death in MI patient in the first 40 days. Although the IRIS and Dynamite studies showed that although it decreases the arrhythmic-induced death, but it doesn't improve overall mortality. This is a debatable topic. And WCD should not be prescribed in a patient who has some other reasons of death more than arrhythmic death, and whose survival is not expected to be more than 6 months. As with all the device, it also has limitations. First is fitting. It is advisable only in the patient which have chest circumference less than 57 centimeter, although most of the Indian will have fall in that category. And it has no pacemaker functionality. It is all of the external, so there is no pacemaker functionality, no anti-tachycardia pacing. There are a huge component of patient interaction and compliance, and sometimes external noise leading to inappropriate shock. Also in a case of patients having single chamber pacemaker, in which the spikes is counted as a events. And there is no protection when the device is removed, as it is obvious. And there are certain comfort issues due to size and weight of the device. Around 10 to 15% discontinuation rates are there, seen in the observational studies. It has also been approved for pediatric patient in December 17, 2015, USA FDA approved. And the body weight of the child should be less than 40, should be at least 41 pounds, and the chest circumference should be 26 inch or more, which corresponds to on average 8-year-old child or more. And recently in the 2017 HRS meeting, there was a huge registry of the around 450 patients in the pediatric patients, and they recommended that its use in the children is safe. So take home message is sudden cardiac death remains an important and preventable cause of death, It is reasonable when there is a clear indication for an ICD and there is presence of transient contraindication to an ICD. Also, when there are clinical situations in which there is a more chances of arrhythmic risk. Risk counseling and discussion of patient's preference are integral parts of patient care and WCD therapy. I acknowledge Jol Medical Company and YouTube Jol Medical for providing the material. Thank you.